Okay, so starting back up with this study from JAMA, they were looking at the association between RHC use, right heart catheterization use, during the first 24 hours of ICU care and subsequent survival, length of stay, intensity of care, and cost of care. So they had 4 outcome variables: the survival, length of stay, intensity of care, and cost of care. This was a prospective cohort study. That means, of course, that they got participants in the study and then watched them, track them into the future. The setting was U.S. teaching hospitals for a certain period. The subjects were critically ill adult patients receiving care for one of 9 pre-specified disease categories. These include the following listed. I'm not going to go into all of those. Exposure is whether or not they got the right heart catheterization or not. So notice this is dichotomous. So you either get it or you don't. This was, of course, done at the discretion of the physician, and thus may reasonably be confounded with patient factors. Okay. Now, ideally, from a statistical point of view, we would have asked that the use of the catheterization would have been randomized, but perhaps in medical situations that would not be an ethical thing to do, especially if the physician already feels like, well, if I get a patient with this kind of profile, I really believe that their outcome will be better. We would never want to put a patient at risk. The disease here. So you remember how I said the disease is not always a disease here. It's that disease outcome is survival, cost of care, intensity of care, length of stay in hospital, ICU. So here we're using different methods. So when you analyze length of stay, when you analyze survivals, length of stay, I don't know if they're doing time to survival or what, or time to death. It depends on what they mean by survival. I think just like mortality, actually. So then that would be binary. Cost of care, you could probably use linear regression. Intensity of care, some categorical method, McNemers. And then finally, for length of stay, you'd want to use a survival model like Cox proportional hazards. Okay, so for the estimation of the propensity score, we would be estimating the probability of having that right heart catheterization given that set of covariates. So the choice, again, for the catheterization was at the discretion of the physician, and treatment selection could be confounded with certain characteristics. For example, patients with a low blood pressure may be more likely to receive the RHC because maybe the doctor perceives they're less likely to have problems. A panel of 7 specialists in critical care specified the variables related to RHC use. That's really nice. I never get any panel helping me decide. So that's awesome. Then they use logistic regression for the propensity score estimation phase. So remember the estimation phase, then the application phase. So for the estimation phase, here is all of the covariates included. You can see this was coded in R. Notice that none of these are the outcome variable, which is any of those disease. The length of stay, the survival, the cost, things like that. Adequacy of the propensity score to adjust for effects of the covariate is assessed by looking at a balance table. So you model each covariate as a function of the right heart catheterization and the PS quintiles. If there's no detectable imbalances, there are no detectable imbalances if RHC is not related after the propensity score adjustment. So that's how you decide. Okay, how do you decide upon what a match is? Well, that's like, you kind of have to really think hard about this. You can't just say there's one bound for this. It's very contextually specific. So each right heart catheterization was matched with a case where they did not receive that catheterization, but had the same disease category to within plus or minus 0.03 of the closest propensity score. So they deemed that window maybe there's other methods you can use for helping you decide what that window is. Like I would choose a few of those covariates that you think are highly, highly associated with RHC, and then use that to help you decide upon the breadth of that window. The difference in the propensity score for each pair calculated, and each pair with a positive difference matched with a pair having a negative difference that's closest to the same magnitude. This assures that there's equal numbers of pairs with both positive and negative. Why would that make a difference? Think about it. This kind of creates symmetry in the data so that we're not biasing those results based upon the adjusted propensity score method. They resulted in 1,008 matched pairs. So here's often how it'll look like in a table. So they did this for the survival. So this was like a survival analysis, classic survival analysis. I wasn't sure when they said survival. I guess that's obvious now that I think about it. Here they're giving the number that survived at 30 days, 60 days, 80 days, those who left the hospital, okay? Obviously, we presume they survived after leaving the hospital. We get the number for RHC negative and RHC positive. And then the relative, or the odds ratio, not relative risk, odds ratio comparing that. So this would be for a patient with or without RHC. It's not clear by this table, actually, but we do see, because 1 is not included in the confidence interval for the odds ratio estimator, that there is a difference based upon RHC for 30 day, for 60 day, for 180 day, and definitely for hospital, okay? So you could use a regression adjustment or stratification method as well. You still create your propensity score, so you still go through that estimation phase. It's just that the application isn't using matching. So I go back to this article all the time, Rosenbaum and Rubin. They showed that this stratification method will produce strata where the average treatment effect within the strata is an unbiased estimate of the true treatment effect. I think it's a really cool way to do it. I really like this approach, but it's hard to, people just like matching better for some reason. So I think this is a really strong approach though. So let's see an application here. The effectiveness of right heart catheterization in the initial care of critical ill patients, the same. Here we can go back and get the data set. We're again looking at the association between RHC and these different outcomes. Same basic thing. Here, exposure. Swing 1 is coded 1 if they received the RHC and 0 otherwise. Okay, so that's going to show up in the results. Then T3D30 is time to death, and it's censored. If they die, of course, then we have to cut it off earlier. And we're going to use Cox proportional hazards model, which you might not have used before, but this is just the way you model the survival type. Time to event is really what it is. The event here is death. Okay, so first you might look at some survival curves, which these are classic Kaplan-Meier survival curves. So we see that among the RHC, that this is all in R, you can tell. Some of the code is up there. But in the RHC, there's a good separation, first of all, I'd say, between the RHC and no RHC groups. And then there is a bit of an increase in the difference in survival for the two groups over time. So at first, and this is quite reasonable, I think, makes a lot of sense. First, you see very little difference, but then you get out closer to 30 days and there is a more detectable difference between the two, RHC, no RHC. This is the cumulative incidence of death, okay? Then they do logistic regression on this. They used these. I'm not going to look at all those. I like that they did this. I like to look at the propensity score distribution because often, and this is one of those cases, you see a real difference in the propensity score distribution based upon these treatments, okay? Survival is very, or the propensity score distribution is strongly right-tailed here, where most of these no RHC group have probabilities very close to 0 for death. And we saw that in the survival curve, or the Kaplan-Meier curve, versus the RHC group has this here. So you really can't make this really shows why you can't make that comparison. You're comparing apples to oranges here. So you create the quintiles. This is a standard way to create, like use a, I forget what I use in R, but I don't think it's this. But it's pretty easy to do in R or SAS, proc rank and SAS, and there's another function in R I can't remember. And then I like to provide a balance table like this. I think this makes a lot of intuitive sense. Prior to the propensity score adjustment, there was an age between the RHC and non-RHC group that was significantly different with regard to age, that was significantly different with regard to gender, whatever the Apache score is. I've heard of that before, but I don't remember. The weight, the mean blood pressure, the respiratory rate, the WBC, the creatinine levels, whatever that is. So there's all these differences. So you really are going, I have different patient populations. Different patients are getting RHC than are not getting RHC. After the adjustment, propensity score adjustment, there is really no difference with regard. So we've matched cases that are very similar in age, gender, Apache score, weight, mean blood pressure, respiratory rate, etc., so that we can really isolate the effect of the difference between getting this RHC or not. That's useless. Let me go move on. So then what I like too is you get to look at all of these. Here it's hazard ratios. Since we're using a Cox proportional hazards model, you can they're kind of similar to a relative risk. Here we have the unadjusted model, which estimated the hazard ratio to be 1.3. After they added some covariates, it was 1.24 for the hazard ratio. The first one was without covariates. The third one was propensity score adjusted with a linear term, and it was 1.22. Then propensity score adjusted using quintiles. So I like this approach in that they present all of them, because sometimes it's better to use the quintile, sometimes it's better to use the unadjusted continuous term. Okay, so we see in all cases, if you had just presented the first two results, a reviewer would have gone, yeah, but you can't really make a claim about this because these patients are different. Now that you've done the propensity score matching or adjustment, you've provided some quasi-experimental evidence that this difference truly exists in the treatment. So in conclusion, when you have a large number of risk factors in a small number of events, this is really useful. And it's useful for creating a matched design while not having to invest all the time and money that experimental designs really require. You can only adjust for the observed covariates. So if there's missing information that actually really influences the outcome, you're out of luck. This method, this no propensity score model is going to help you there. There's really nothing you can do except get data with that information. Then propensity score methods are better when you have larger samples, so that you really get that distributional balance of the observed covariates that we saw in that balance table. Bias can still occur, but there's that balancing of the deviations to kind of guard against that. Reducing irrelevant covariates, or including irrelevant covariates, may cause problems with convergence and things, so don't do that. References, I'll provide these so you can take a look, but this is all the stuff that Lisa included in her presentation too.